right, we will get started since it's 5:30. So if you guys want to, there's food. And so I'll do, probably I have like somewhere between 30 and 40 minutes of stuff to go through. And so if you have specific questions, you can ask during, but most of the time I'm probably going to answer at least part of your question. So if you can wait till the end, that's great. You'll have time for questions and answers at the end, so we usually have quite a bit of time for that. So there are some notepads if you guys want to write down your questions so you don't forget them, because a lot of times that's what happens too. So feel free to write them down. But if you do have something burning, go ahead and ask the question. But again, we try and just wait till the end, so that way, because most of the time I go through it. So I'm Dr. Gianna Valine. I'm one of the family practice and primary care sports medicine doctors here at Rejuv. So I'm also a specialist in interventional regenerative orthopedics, and we'll talk a little bit about what that is and what our training is. So my background is the same as Dr. Baumgartner, so both family practice, and then we do sports medicine. And then we do a lot of extra training in the regenerative medicine world. And regenerative medicine is really where you're trying to use your body to help heal your body. And that's also including lifestyle factors. So I do a lot with medical weight loss, a lot with the lifestyle medicine. So that's a big piece of what we do. And as you can kind of see, like how we're set up here, that's part of Rejuv, is we have the fitness, we have the therapy, we have the different departments, because it's not just about injections, it's about how do you actually maximize that and figure out what's going on. So we're going to talk about some different ways. And so becoming, I kind of put this up here because people kind of consider this alternative medicine. They consider us alternative doctors. And alternative just means it's something different. It's a different option. It doesn't always mean it's a bad thing. It doesn't mean that there's no research behind it. So people always kind of use this word, alternative, meaning that's probably not that great. And I think that's kind of a disservice to what alternative means. It means a different option. So start to think of it that way. It's not always the traditional options of what we've been taught in school. And so you have to remember that when we go through medical school, we get very specific training by those who are trained by someone who is trained by someone. And so you get that trickle down of all your mentors. You interpret the studies the same way, and you kind of get taught this is the way we do things. And they always encourage you to ask questions, but it's kind of like the right questions. And sometimes you start to ask the different questions. It's like, no, it's just because that's not how we do things. So when we do our training, a lot of it's fueled by big organizations, by money, by what has been trained in the interpretation. And so part of, as we talk about this world, is like, why do we do something alternative, and why have we chosen that route, and why do we believe in it? And also, why do other doctors not know about it? Because I think that's always a hard part. It's like, why doesn't my doctor know? Well, they weren't taught that. And so I happened to fall into Rejuv. I worked north of here an hour. I had no idea what any of this stuff was. I didn't know what nerve injections. I sort of knew what stem cell was. I had never heard of prolotherapy because no one taught it to me. No one talked about it. It was still anti-inflammatories, steroids, cortisone, and then surgery. So we have to be easy too on our doctors. I'm like, we don't get taught this. And so you have to really go outside the norm of all the people who've mentored you for years and years and years to say, hey, whoa, what you taught me was wrong. I want to look at something different. Then you have to find the right groups, because there's different groups of people doing this, and you have to find those right groups who are actually doing it correctly. And so you're kind of going against everyone that you've worked with and trained with and who has taught you. And so it's a hard thing to do, and it takes some time. Plus, a lot of times the places you work aren't really okay with it. Like, you can't always go to like a big healthcare organization and say, hey, I'm going to start doing some stem cell and hormone replacement. Like, they're going to say absolutely not. So you kind of have to understand that context too. So part of it's educating you guys on what all your choices are, so you know what your best options are, and you can educate. And then how do you also educate if you're going somewhere else? Because if you just walk into a doctor's office and give them, hey, I printed this off from Google, right? They're not very happy. Like, they kind of put the defenses up right away, and because they're just not open to it. So how do we start to approach that conversation? Because you guys will help us teach other doctors and other healthcare professionals and other providers that these things are out there and that they work, and they work very well, and they work in the right conditions. So this is my mom, and so this is just kind of a little bit of background. Some people, they're always like, oh, what would you do if it was you? What would you do if it was your mom? What would you recommend? And I do have to say, I did tell my mom all those traditional things when I was still doing the traditional practicing of medicine. Her and I started running, I ran for forever. She started doing races with me when I was in medical school, and so she ended up getting ankle arthritis, not from running. She actually was playing with her grandkids and sprained her ankle. And so she ended up with ankle arthritis, and I told her, okay, Mom, just do some anti-inflammatories, no big deal. Do the topical ones. She worked for a little bit, and then it stopped working. And I was like, oh, it's fine, you just need a steroid injection, because we're still running a lot. So she went and had steroid injections. And so it was one of those things that she did the same thing, where each injection worked, and then it worked less and less, and then eventually she ended up with surgery. And so she ended up with an ankle fusion. During that whole time frame, I started to really dig into why aren't these things working? And I think when you have patients come to you, the assumption always is they're not telling you the truth. And somehow that's what we were taught in school is like, oh, I must know the best. And we don't. Our patients are already telling us what's wrong and they're already telling us what's going on. And so hearing her say this, I dive in and I was like, oh, anti-inflammatories are not good. They're really not good for us. Look at all these risks. Like, I don't want you taking these anymore. They're not helping you. So you just dive deep into that. And she kind of missed the big boat as no one prescribed narcotics for her. And that's a huge problem we have too is the opioid epidemic because that's, oh, here's your anti-inflammatories. That doesn't work. Here's your narcotics. That doesn't work. Here's your steroid. And so we start to look at these things and realize, are they not only not working for a lot of people, they cause a lot of negative effects. And so, the anti-inflammatories are, that's your ibuprofen, Advil, leave group. They lead to early arthritis. They can lead to cartilage breakdown. They have poor bone healing. And the list of other organs goes on and on. So the heart, the kidney, the liver, all those areas you can find something. So I think to understand that. And then the narcotics obviously have their whole own problem. And so we try and stay away from those. And then we say, okay, well, prednisone and cortisone is bad. Cortisone and steroids aren't very good. It's both the anesthetic that used in the large dose of cortisone is actually really bad for your joint. It causes more breakdown. And if you think about it, so we tell people, well, the first one will work great, and each one you do, it'll work less and less, and eventually it'll stop working. And why would you do that? Shouldn't it be something, if it's helping you, that the more you do, the better you get? It should be the opposite of that. So when you step back and think about all the times I told people, I'm like, that doesn't make any sense. Like, why are we doing this? And so then you say, well, we're going to take all those things and put them over here. What do we have left, right? So you're sitting there with this very small toolbox of things, and you don't know really what to do for people. You try and talk about lifestyle, and you're not allowed to because if you're running behind, you get dinged. And so, it's trying to find not just, patients, but also a healthcare system that's open to this, that I can help people a lot more by talking to them about how do I change your diet? How do I get you moving better? How do I get you out of pain? How do we do all these things to help you have a better quality of life? Then there's also these injections that we can do to help as well. So that's another piece of it. We need to have all these tools. We need to have the resources. And so that's the other part is you need to have, I can't do all the counseling for everyone every week, but I need to have someone to send people to. We need to have resources that we believe in, that we recommend. So that's what we've tried to develop here at Rejuv is that where we have this team approach and we have the resources and we have our different departments. And so, I think something that always happens is, well, my husband and I did a lot of traveling. We did some locums, we did some mission work, and people are always like, oh, America, like, well, it's great. And it's great if you have something really bad, right? So like if you really, truly are sick, we do amazing health care for trauma, for emergency, for people in the hospital. We do great care. We're really horrible at primary care and preventative health. We're really, really bad at preventing the problems. Once you have it, we'll pay for it. We'll give you all the medications you need. You can see the doctor as many times as you want to. So we're really good at treating people that way. We're not really good at prevention. It's not because we don't know how. We know how, we just don't have the time and resources to do it. So that's part of the healthcare system that we need to develop. And so it's just one of those things as you travel and it's like, yeah, it's not as great as people think. We have lots of positives here and there's a lot of benefits, but you still have to kind of take that into context that, we're just really not good on that side. And so part of Rejuv Medical is the clinic in our department, and then we are affiliates of Regenix. And so Regenix is based out of Denver, Colorado, and so they were the first ones in the U.S. to do stem cells back in 2005. And so we do training with them. All of our lab protocols and everything is part of Regenix. And so they have a lot of research. They have more than 50% of the research that's coming out on stem cells. And so we kind of are always getting updated on what they're doing. And so when we post research on our website, like that is what we're actually doing. And we'll talk a little bit why that's super important. And then through them, we get a lot of training. So there's lots of different organizations. And again, some are doing it really well, some probably not as well. And so we're, in conjunction with different organizations to get certifications, to get further training. And we're constantly going, because this is a new field, so it's always changing. You're always learning new techniques. You're learning new ways to do things. There's new products out there. So you do have to definitely stay on top of it. And so question is, now we have a broken down joint, and a lot of times what happens when you have pain in a joint is you start to feel crummy all over. And so, a lot of patients that say, I was fine until my shoulder started hurting, and now I feel like I completely fell apart. And so I think we have to understand that concept of what happens when we get pain, what happens when we get arthritis, what happens when a joint starts to break down and starts to get degenerate. People become very focused on that arthritis where in the degeneration, the cartilage, the meniscus. They focus on those words that an MRI sees, but we forget a lot about the lifestyle. We forget a lot about what happens when you have pain and you don't sleep very well. What happens after months of not sleeping? What happens to your hormones? What happens to your metabolism? What happens to all of these things in your body that are going on that's trying to heal you and you're not healing? And when you don't heal, what happens? What happens to your stress level? It goes up. What happens when you don't sleep? Your stress level goes up. You can't heal. You can't repair. And so we have to look at those factors as well. When we start talking about arthritis, we have to go outside the joint. We have to talk much bigger picture. So when we start talking about regenerative treatments, a couple of things that I like people to think about is that bigger picture, but also we need to start looking at like the basis of support. So knee is probably a great example because knee arthritis is one of the most common. And so when we start talking about what does regenerative therapies mean, what are we actually doing? We have to look at like, well, where is the area that's causing you pain and why did it happen in the first place? So if you're going to use your body to heal your body, you need to have a really good basis of support and you need to have good cell health. And so that's where kind of we look at this like each department, which is we use a lot of bracing and we use physical therapy and then eventually out to the gym. That's your base of your strength. So how do we stabilize that joint? How do we help while you're in pain? Do we help the ligaments and tendons do what they're supposed to do and offload that joint? And that's where that comes in. The other piece is if we're going to use your body to heal your body. So that's the movement piece, is how do we keep you moving? I can almost find something for everyone to keep doing. Like, people are like, oh, well, I can't exercise, so I can't lose weight. Well, it's really untrue because it's mostly nutrition. So, I think that piece that we kind of play it all on exercise when really we need to be looking at, sleep probably number one, stress number two, then nutrition, then probably exercise. And so exercise is great for weight maintenance. So when people say, I'm like, I can find something to keep moving. It might not be what you're wanting to do or that you're like, oh, I got to burn this many calories. But we got to kind of get away from thinking of that and just think about how do I keep fluid? How do I keep moving? How do I keep my body going? And we can give people, and that's why we have different options for people in different levels to keep them moving. The functional medicine, nutrition, lifestyle, supplements are all, if we're going to use your body to heal your body, how do you actually make sure that kind of incessantly. And so I just think it's so important we don't talk about that part enough. And so making sure we have the time to talk about that and then the resources, and we have a lot of that. And then the supplements, and I'm someone with supplements where, we have a lot, but I want you to be on supplements for a reason. So I don't want supplements to ever turn into a prescription medication, which is, here's my list of supplements. Well, why are you on those? I don't know. You should know every supplement you're on and why you're taking it, and if you truly need it. And can you do it with food instead? So if you can do food, supplements are meant to be a supplement to your diet and good nutrition and good lifestyle. So I don't like when people have a big list and don't know why, because to me it's no different than having a list of 20 prescription medications and not knowing why. So we really need to understand why we're on things, why we're taking them, what's the purpose. And so that's a big piece of what we do. We do a lot of work with nerves. So nerves are kind of been underestimated. Like people sometimes get a diagnosis of a specific nerve pain, but they've been really kind of shoved under as far as being a really big instigator of a lot more breakdown, a lot more problems. We do a lot of work with nerves. Then obviously the Prolo, the PRP, and stem cell. So the nerves, Prolo, PRP, stem cells, more of our ortho sports med department. Then we have more of our functional medicine, lifestyle, and then definitely kind of more PT and gym. And so this is a patient I had. She was 62. She was 72 actually. And so she came in and she said, I want to walk my daughter down the aisle at her wedding. And I was like, all right, okay, it's cool, we can do that. And then we started talking, and she had really severe hip arthritis. She never really said that her back hurt, but I kind of kept, explaining to her, like, well, let's talk about your back a little bit. She had, really intelligent gait, meaning she limped quite a bit. And so we talked a lot about, expectations, because there's a lot of things that go into bad hip arthritis. There's a lot of things that the back contributes to. And, really what her expectations and her goals were. And so we talked a lot about, okay, how can we optimize your treatments if we're going to do this, if we're going to treat your hip? What do you need to do and what do I need to do? So we made a plan where we did some different nerve injections, some dilation injections of her hip. And I got her to finally let me treat her back. It took a while. I was like, I just think you're back. And, we finally did a different type of epidural that we do here that's different than other places. And she's like, oh my gosh, I feel great. Like I can actually move a little bit better. And so I think sometimes to just understand that everything's connected in those pieces. And we eventually it's a complex problem. You know, having hip arthritis is not just hip arthritis. It's what happens and why did it happen in the first place. That's why I kept saying, let's look at your back because you've had bad hip arthritis. Like, let's look at your back. Let's treat both areas, because when one area starts to break down and wear away, what happens is the ligaments that are supposed to be the tight rubber bands of that joint starts to wear out. The tendons of the muscles that are supposed to support that joint break down. The joint environment itself gets pretty unhealthy. So instead of being kind of this nice, robust environment, an arthritic joint is a very unhealthy joint. It's probably the easiest way to think about it. It's just got a lot of junk in it. Your body's trying to clean it up, and it doesn't do a very good job. And so that's where a lot of the lifestyle medicine factors in. And that's probably why a lot, you know, when people start looking at studies on hip and knee replacements, is they're not 100%, because taking that arthritic joint out and replacing it is not the only problem. There might be knee issues, there might be ligament issues, there might be imbalance issues, there might be other lifestyle factors, hormone, metabolic. All of these things play a role. And so once we understand that, we can say, okay, that makes sense. And then people ask, well, why does PRP and stem cell work? Well, I probably didn't regrow back your cartilage by the time you get pain relief, but you get pain relief. And so we know there's other factors playing, and we're figuring that out. We're figuring out more and more what's actually happening. And so the way that regenerative therapies work, so for her we did stem cell because she just needed the most potent because of the way hips are. Oops, sorry. And so when we start talking about regenerative procedures, that's what we mean when we start saying we're gonna use your body to heal your body or use something else. And this is really where you want to know there's actually more than just PRP and stem cell. There's actually something called prolotherapy, which has been around for over 80 years. It's actually using dextrose in the same technique to inject tendons, ligaments, joints. Has lots of studies behind it. Works extremely well. People just have never heard of it because it's cheap and easy and doesn't make a good TV show. So, you know, that's, I think, part of that is we need to understand there's other reasons. And if someone's only talking about stem cell, they're probably not the person you should be seeing. If they're saying stem cell is the only thing that's your only option, then they don't know enough about what's going on. They don't know there's other options. And I pick and choose from these based on the problem, the person, what I'm seeing. We have very long exams with people. So we sit and we talk to them. We go through their history, do a full exam. We do imaging studies. We really look through, and then we make these choices based on that. So understand there's more than one option. The way that these all work in general is you're actually starting a healing cascade. So the initial stages of healing is inflammation. So you want short-term acute inflammation for healing. And that's why you don't want to do a lot of ibuprofen, Advil, leave steroids. It actually inhibits your natural healing response. You don't want chronic long-term inflammation. So we want this short-term response to start the inflammatory cascade and put you back through into a healing phase. So there's lots of other things going on. It's very much simplifying it, but that's kind of the gist of what's happening with these. And they all do it at different levels. So I kind of think about, so my son's into superheroes. So sorry, I was Paw Patrol for a while, and that worked really well. But then I wasn't allowed because now he's older, and he's not that old to be superheroes, but he is. So we get to hear all about superheroes. So I think about like Prolo if you just had one of these guys, right? Like you had one person to go and do the job. They could do it, it just would take them longer. So there's not going to be as much like damage of surrounding structures if one guy's only fighting one bad guy. So it's going to take them a while to do it, but they can eventually do it. And then so it's not as potent. You don't get as sore afterwards, not as much downtime, but just takes longer. PRP is kind of in between. So let's say you had 2 or 3 of these guys. So you're going to have more robust of a response. So it's going to work a little bit better. It's going to take less injections. It's take less injections than Prolo, but more than stem cell would. So it's kind of your middle ground. There's also some properties of platelets that are very good for spine issues and for certain nerve issues and for certain parts of arthritis. So we sometimes choose that as well, based on the degree, and kind of your mild to moderate tendons, ligaments, sprains, strains away. So part of arthritis, so part of what we're choosing. Then I look at stem cells, like you have all of them. So you kind of have the leader, which is going to be your stem cell, and they go in and say, hey, this is what needs to happen. You're going to do this, you're going to do this, you're going to do this, you're going to do this. And so then they start that healing process as they go in and they tell everyone else kind of what to do and to start that process. And that's why stem cell probably, and we don't know this exactly. Again, this is simplifying, but it's kind of the gist of how they work is that's what you're doing is you're going in, and who knows how long those stem cells are in there. Are some turning into cartilage? Probably. Are some in there forever? No, but they're starting that healing cascade. Same thing with the platelets, same thing with the prolotherapy is they're starting your body's natural healing cascade to keep that healing going. And so for her, she danced. She even sent me a video of her dancing at her daughter's wedding. And so it was awesome but this was like a year process. I mean, so this was something that her and I had this honest upfront conversation, which is, this is a journey you're going to take with me. This is a process. And so, we're going to see how one thing works. And if it doesn't work well, we'll change course. If it works well, we'll keep going with that. So understanding years and years of breakdown degeneration, I can't fix with one injection. I can't fix it overnight. And so that, my job is to help to help you be able to do your job. And so we have to work together, and it definitely is a journey. It's a definitely, you know, some people, yeah, they have a lot less injections, they have much minor, you know, more minor problems. We get rid of their pain, they sleep well, they feel great, and everything's awesome. And so that's another movie that we watch a lot of, is Everything is Awesome, the Lego movie. But so, you know, that's some people's course. That's not most of what we see here. And so when we start talking about kind of how do you say, am I a candidate? I think that's why we need to have a visit with every single person to talk you through, what kind of candidate are you? What kind of work do we need to do ahead of time? Do we really need to treat your pain first because that's a big instigator, and then understand you might need more procedures afterwards? Or do we get your lifestyle in order first? And so where we've combined this regenerative approach is to use our regenerative therapies and then do all these other services to help maximize your outcomes. So when people say, well, how long will it last? What will my outcomes be? You know, how much relief can I get? I'm always, you know, one of my questions is like, well, how much are you willing to do? Because I do my part, and in order for my part to work the best way, I need everyone else to do their part, and then I need to give them the resources and the tools and have the time to work them through that. So it really needs to be a collaborative approach between, you know, the patient and the doctor on how we get these good outcomes, because that's how we're going to help the long-term wise. So it's super important to understand that, you know, it's not just about the stem cell. It's so much more that goes into it. And we walk you through that. So people leave here, they probably feel a little overwhelmed, like, oh my gosh, what just happened? But that's what people are really wanting, is they want all those tools and resources. And we're so used to the traditional healthcare model, we kind of forget, like, oh yeah, there are other people out there who actually have looked at this differently and are going to help me change my life. And so she did her work. She did great. We just kind of do like intermittent treatments now, just for maintenance, and her and I have been in contact. She's doing really well. So, you know, we did a lot at first, and again, the more we did, the better she got, and the longer she goes, and that's really the way that it should be, not the opposite of what we used to do. And so this is another patient I had, and she was a little bit different because she kind of came in saying, I want stem cell. She had bad knee arthritis. She had looked it up. And so I was like, all right, that's okay. Like, that's reasonable. You have bad knee arthritis. Let's talk about it. And so as we were doing her evaluation, she actually had significant atrophy of both her quad and calf on the side that she had arthritis, which could have been from that. She couldn't fully straighten her knee. And so her and I started talking through a lot of the, like, okay, low back issues again, what's going on with your gait? Let's fix some of those dynamics. Why did this happen? Why do you have atrophy? And she's like, yeah, I've always wondered that, but no one's really ever, like, been concerned about it. So we talked a lot about the functional movement piece of why one side was breaking down. And so she did the bracing, she did the therapy. We worked a lot on that piece of it for her and really rehabbing it both before and afterwards. And so one of the things when she came in, you know, she was actually really just kind of scope out, like, what kind of stem cell do we do? Because she had looked up some different types. And so there's some different types of stem cells. So adult stem cells, typically it's being done when we're talking about fat or bone marrow. Embryonic we'll talk about a little bit in brief. So we're talking about the adult stem cells. And there's some different types you've heard about. So typically here we specifically do bone marrow. And so right now it has the most research behind it. It's the safest from a procedure standpoint. And so we stick with that because you get the most numbers. We have our technique down. Embryonic and amniotic is in a different category. So there's been 3 different places now that have independently tested the embryonic and amniotic and have not found stem cells in there. So it's not that they're not helpful. It's not they don't have a place. We just have to understand that we shouldn't be calling them stem cells. And so because if they are stem cell therapies, if there's truly stem cells in there, they need to go through a different FDA approval than what the bone marrow is going through, because they're not coming from your own body. And so again, I'm overly simplifying it, but understand that embryonic and amniotic, I'm not saying they don't work, I'm not saying they don't have a place, but they don't come from your own body. And so they have to go through a different regulation if they truly had stem cells in them. They be the same as a drug, not a tissue. And so they have to go through a completely different process. And you have to think too is, like, what do you do those products? Well, they're gamma irradiating them, they're doing different treatments to get rid of all the cells. And so I just caution you. I mean, again, someone should be calling them amniotic therapies or amniotic growth factors. We should be calling them something different, because if they call them stem cells, there's no stem cell in there. It's against the FDA from a legal standpoint because of false advertising, false marketing. If they did, then it should be a drug, not a tissue. So just kind of caution with those. Fat, some people really like and are probably has some promising results. And so that was her question. She like, well, can I get a 2-for-1? You know, a liposuction with stem cells. I was like, well, it's not that kind of liposuction. So, no, and she was kind of joking, but not really. And I was like, nope, it's not a 2-for-1. I'm not a plastic surgeon. And so these are considered mini liposuctions. And so, you're not going to have like all of a sudden this felt figure like after you do your stem cells. So understand that too, that it's a mini liposuction. It's not a true liposuction like you're going to have from a plastic surgeon. So, so that piece of it, I was like, yep, nope. And so, and fat also has some problems too with how you process it. So it does come from you, so you have that benefit, but it's the processing that gets into trouble. So if someone's doing the fat stem cells, you have to make sure that they're within the regulations of processing it, because if you process it to get the higher numbers, there's some concerns with the FDA regulations. So I think there's going to be places for all these as we figure all of this out. It's just calling it what it's supposed to be called and making sure our marketing, our advertising, and that we're actually saying what it is. We have the documentation. So, and then this is actually for bone marrow. People worry it's not a bone marrow biopsy. So people are like, oh, I've known someone who had a bone marrow biopsy. It was extremely painful. These are bone marrow aspirations. We're pulling it off. And so most people say it's a 3 to 4 out of 10 out of pain. They say it's not that big of a deal. So, and when you look at the side effects, there's really some pain and swelling maybe. And this is both for the bone marrow and for anything after, for the post-injections as well. So it's pretty minimal as far as side effects go. It's very safe. Most people say it's not that bad. And usually afterwards, like it hurts at the time, but afterwards it's not. People have really very little pain. And so some people are kind of talking about this like Wild West of stem cell, just mean that it's the good and bad, which it's like no regulation is sometimes really nice because we get to pick and choose and actually make the best treatment plan. But then sometimes the regulations, you're like, oh, who's doing this down the street? Who's doing this over here? You're hearing all these bad things about certain places, and no one really hears about all the good things that are happening. So we can't lump everything together. And that's a lot of the work of these organizations that we belong to, is trying to sort that out. Who are kind of the good players doing it correctly, and who are the people who probably aren't doing it like it should be done? Because that's where the problem will come into with insurance coverage and research and what works and what doesn't. So when you're looking for a clinic, make sure you're asking, like, who is it? Like, what are my options? You want to be meeting with the person who's doing the procedure long before you have the procedure done. So some clinics you meet with someone else, you come to somewhere like this, and the next day you have stem cell. And I just don't think that's really appropriate. If they're only talking about stem cell, I'd also ask more questions. Well, what about these other options? Making sure that, the research they post on their website is actually what they're doing. And so if they're doing fat stem cell, but they're posting bone marrow, they're not the same. They're not equivalent. If they're doing, PRP, but they're posting stem cell, they're not the same. So your technique, the product, that all needs to be the same, and how you're injecting it. And so that's where some of this is trying to sort that through as a patient can be really hard, in trying to ask the right questions. And so kind of think of it this way. Are they able to tell you this? Are they able to go through all your options and give you what is the right product? Are they going to put it in the right place? Is it by the right person and at the right time? And so when we talk about product, okay, Prolo PRP stem cell, you're looking at the right place. We'll talk about that in a second. Who's doing it? Who's the person actually doing it? Are you meeting with them? Are they a doctor? What's their credentials? How many have they done? Where have they trained? And at the right timing, are you optimized for this? And is this really when it should be done? And so when we talk about the right place, is if we just squirt in your joint, yeah, you might get a little bit of a result, but we talked about all those structures that are actually supporting something. You need to inject those. And so we use image guidance to make sure we're getting all those areas. So we're kind of over here at this far end, we're the 5% of doctors that are doing these very precise guided imaging techniques. So there's a lot that are starting to kind of be in the middle now that are using some guidance, but they're not really very accurate. They're kind of just, I'll just go in the joint and call her good. And there are some that are still doing it by palpation. Now, prolotherapy is traditionally done without ultrasound guidance. So if you're seeing a prolotherapist, we'll have a different conversation. Works very well. But when you're talking about PRP stem cell, more advanced techniques, they need to be going to where they're supposed to be going. The other piece is why. So, you have to be able to examine someone and talk them through a history and do a very good exam and say, I know where your source of pain is. I know where your laxity is. I know what your problem is. So you have to get the right diagnosis, because you can be a very good injectionist and put a needle anywhere. But if you don't know why you're putting that needle there, if that's the right place, you're also not getting that whole big picture together. So some different things you want to be talking to them about. And not that we're always perfect, but again, if something doesn't work, I'm always looking back, well, why didn't it work? Was my diagnosis right? Did I miss something? Was it the wrong product? Was there something else lifestyle-wise going? The other things to look for is, what is their clinical research? So, again, since we're affiliates, you want to know, okay, are we posting what we're actually doing? Are they tracking patients? And we track all our patients in a registry. And then are we changing based on the guidelines, are we changing our treatments? And yeah, you need to be doing all these things and finding someone who's doing these. And it's fine to ask these questions. And not everyone, again, is going to be perfect and at the level they need to be, but you should be looking for this because they're definitely out there. There's fewer and far between. And so as far as she went, so she was just a fun patient because we kind of it was just fun to have someone who knew about stem cell and was like, yes, I'm getting this. And we talked about so much other stuff because it's like, all right, we're going to do your bracing, we're getting the therapy, here's why you need to do all these things. And a big thing for her actually was she had a lot of gut issues. So she actually had pretty severe IBS she had some other inflammatory conditions. And so we did a lot with functional medicine, the supplements, or IV therapies. Because again, for her, if she didn't have that nutrition, if she didn't have that base to support, and so she was kind of surprised because yeah, here she comes in for stem cell training. I'm like, well, yep, we'll do that fine. But what about your back? What about your atrophy? What about, your gut health? And so it's kind of fun when people have been like, yeah, I've been wondering about that. I've kind of brought it up a few times and it's kind of been brought, they haven't really been concerned that you actually start yes, someone's finally listening to me. Someone's actually thinking about what else is going on and how these factors play in a role. And so what else do we treat? I talked a lot about knees just because it's the most common of what we do. But we do treat kind of head to toe. And it doesn't mean that stem cells are appropriate for all of these, So we might be choosing some different injections, some different lifestyle things, the functional medicine, the movement. So we can kind of treat almost anywhere head to toe that we can usually find something in Rejuv itself to help you with. But it's not always that the same treatment's going to be for everyone. So we can usually, most areas we can talk about something. And again, if it doesn't work, we're always looking at why didn't it work. And so I kind of brought this up before, will it work for me? And so I did the next few slides. I'm just going to buzz through super fast because they're all of the research on Prolo, PRP, and stem cell. So if you want them, they're on our website. I have a couple of resources at the end. So, and these are not even updated. I have a whole list more that I've been meaning to put up on here. I'm like, but we just put them on our website. As we get, every time we go to a conference, we upload more and more research studies. So, if you see someone, they say, well, there's no research. It's like, well, here's a couple, Regenix, they have a whole bunch on there, their registry, and then this is just for prolotherapy. And this is kind of endless. There's a bunch for PRP, and so each one of these is different studies. There's sometimes 2 or 3 on a page. Evidence for all of these areas, RTC is rotator cuff, lumbar degenerative disc disease, ACL, hips, and so there's even more. So if you start looking at some of these, if you look, they're from a while ago. There's more and more every year that's coming out. Rotator cuff, stem cell arthritis. And prolotherapy has a whole list too. PRP has a bunch. So understand that when people start talking about evidence, because I think that's what we always hear is that there's no evidence for it. Well, there's not really great evidence for a lot of surgeries either. So what's standard of care of what's being done, and then what alternative therapies might be, and what our insurance covers are very different things. So start understanding those differences and sorting through them. When we talk about if treatments will work, and again, if your foundation is crumbling and you try and build a new house on top of it, it's going to crumble again. So you have to have a good foundation of healthy lifestyles, a good support base if you want to build on top of that and get things to heal and repair, because otherwise it's going to break down again. So you need that twofold. And again, that's been happening over a long time. It takes a while to build it up. It doesn't mean it's going to be, 2 years till you feel better. We just still got some work to do. So just understand that you're here with us for a journey. We have the team approach for a reason. And the other is, we're not perfect, and no treatment is perfect. If someone says that they have a 100% success rate, really question that, because nothing in medicine is. Patients teach me every day that I'm wrong, and that's great, because when we look up, why didn't that work like I would expect? Why didn't that one work? Then you start to recognize those patterns. And so, this is a learning process, and so everyone's different, and we have to treat them that way and just not assume because it didn't work, well, it must have been your fault. Let's go back and let's dive deeper. And so we always ask, be patient with us too. We got to find out what's going on. We got to dig deeper and figure out what's happening and what's not. As far as insurance coverage go, just kind of in brief, so at Rejuv itself, your typical visits with the doctors, nurse practitioners, all go through your regular insurance. So if you have insurance, it gets submitted like a regular office visit would. There's a large number of our treatments that are actually covered by insurance. When we start talking about Prolo, PRP, stem cells, those are not being covered by typical commercial insurances. And so that's where I'm talking about. Just because they're not covered doesn't mean they're not appropriate. So your insurance covers a lot of things that I wouldn't say would be the greatest for you, right? Like you can get a lot of cortisone injections. They'll pay for your surgery. Might not be what you need. They'll pay for your prescriptions once you have diabetes, but they won't pay for me to prevent it. So understand that insurance coverage is not based off of updated clinical evidence. And so it's interpretation, there's politics, there's money, there's all these other things that go into it. So just being careful that people sometimes choose based on their insurance, and we try and give you both options. Here's your insurance option, here's your non-insurance option. We'll tell you which one we think is best. If I think there's an insurance-based option that's best for you, I'll tell you. I'd rather have you do that. If I don't think it's the best or something else that's better, we do counsel patients on that. So it does get to be a little bit more confusing because there's so many more options, but those ones are not typically covered. We don't submit them. When you talk about Prolo, PRP, and stem cell, and again, it doesn't mean that it doesn't work. It doesn't mean that it's experimental. It doesn't mean it's not right for you. You're just getting in the mess of politics and money. So we try and just be like, this is what's covered, this is what's not, this is what I think is best for you, and this is what I think you need to do to get better. And the other piece of this is, and so backing up, so my mom did have an ankle fusion, and I'm still mad, but because I didn't know about this, so I'm really mad. And she actually goes to the Mayo Clinic. I grew up down by Rochester, and so so, just remember that not always the biggest academic that people think of as being the best is always up to date on everything either. So anyways, Mayo's great, for some things. And I'm not bashing, I'm just mean she was going to probably what most people would consider one of the premier medical facilities, and she still ended up with an ankle fusion. So they weren't even aware in doing these things. And so she's doing fine now, and the one thing that she had said is, so we actually did a race afterwards, is if I wasn't at this job where she knew that she had an option if her ankle started hurting again, she wouldn't be running. And so she still runs, she still walks with me. She still does what she can because they told her, well, choose your steps wisely. You only have a certain number of steps after this ankle fusion. She's like, that's crap. That's not what I want to do. And just that fear of being in that much pain again, she's like, I will not run again. I will not walk again. That fear of being back in that pain, she's like, I will not do it. And once I started working here and we started talking, she's like, oh, okay, that's cool. You can fix me then. If I start having pain again, I know I have these options. Having that hope that there's something else to fix you does wonders for people. And so we don't want people to have a limited number of steps and to say, well, choose them wisely because that's how you get. That's not a good quality of life. That's not what we're looking for. Now, sometimes, things don't always work out like we want. So I just think understanding too that when we say alternative, we're just giving people different options and they have hope for pain relief, that we really do give a lot of that hope for people. And so I think it's very powerful. That's one thing she always tells me. She's like, yeah, it's fine. I can do whatever I want because I know when it hurts, I'll come see you. So when we start talking about interventional orthopedics, which is what we're doing, there's always going to be need for surgery. There is, but I think we're going to decrease that more and more and more as we prevent things and we fix things and we can do things non-invasively, which is very helpful for patients. It's less downtime away from, less time away from work, less downtime. So people are back a lot faster. It's much quicker. And you preserve your biomechanics. When you start cutting things, you're cutting through muscles and tendons and ligaments and nerves, you have a whole new set of problems. So I think this will replace a lot of things and hopefully prevent a lot of them. So when the surgeons need to do surgery, they're really doing them for the highest level that they need to do. The other thing is they don't have such a great rep. Some people start saying there's no evidence for this. I'm like, well, there's not great evidence for some of what they're doing either. There's a lot of results. Meniscus surgery, hopefully they'll eventually stop and just stop covering because it shouldn't be done. There is, the back fusion surgeries. There's ones on rotator cuff. The list of those kind of goes fairly long as well. So just being careful that that's not, there's risk with surgery. And again, if they're needed, I'll tell you. We send people for surgery when they need it. We just try to make sure they have all their options. They know, can we treat them here? Can we try this? And then do I think you need to go to surgery? Maybe get both options and make a decision. So we still have to consider there's something else out there, but I don't think we're needing to use it as much as we used to. So that is what I have for you guys. So we do have some time for questions, and I know I talk super fast. Someday they'll make Facebook Live where you can just turn it down and slow me down, but they don't yet. And we don't have it on a recorder here. So feel free to ask questions. I will quickly say though, so I was talking about the insurance. So every person is different. Everyone's an individual, and we really kind of thrive on that here, which is our visits are much longer than the typical. We don't have 7 minutes with each patient like the typical primary care doctor does. So our visits are a lot longer because we go through a whole history, we go through an exam, we talk about doing more imaging, do we bring you back to review that? So we try and have a lot longer to talk through all the options. And so that's the easiest way if you want to know if for a specific problem if you're a candidate, because I can't really tell you in like a 5-second, oh, my knee hurts, can you help me? I don't know. I'm saying we probably have something to help most people. And so everyone kind of wants to know, can you help my problem? I'm just saying the best way is that initial evaluation will go through your insurance like any other visit does. And so the ladies are up there at the front desk. They can make appointments with you. Dr. Meehan, who's one of our new doctors, is over here. He started with us a couple weeks ago. Wave. So there's 3 of us now, so our backup list isn't as big. I was just Dr. Baumgartner myself. And then we do have Dr. Robertson, who's down in Savage. So it's honestly the best way, because there's no way I can tell you about, I can't hear your whole history. I can't do an exam. Is if you want to know what we can do for helping, is to just make an appointment so we can actually go through all that and really give you all your options. And that just goes through like a regular visit would. If you've had previous imaging, reports, doctor's notes, try and bring those in with you. That's all very helpful for us. We get more if we need it. So that's all very helpful. So that's the easiest way, just so we can give you a really honest answer. Because otherwise I don't know your whole history and your exam and your imaging results. So try to think of anything else. Otherwise, questions. We have time for questions. Yes.
If you've had a previous rotator cuff tear and surgery, and now you find out that you have another rotator cuff and your cartilage is gone.
Mm-hmm. And that's what I'm saying. Is there still options? I might not be able to completely replace all the cartilage, but we can do a lot for pain management. We can help the function. And so that's why you have to look at the imaging, because part of it depends on if, what that imaging looks like and what your exam shows, because that helps guide us on like, okay, this is what I think your expectation should be on if we treat this and which one makes the most sense. Because it might just be, well, we're trying to work on pain relief for you because it's in 2 pieces, they're completely detached, and there's atrophy. So what can we do instead versus, oh, there's a re-tear, but it's still, close together. What might other options be? Yeah. Yeah.
Is there a problem with Medicare?
Not for just that's what I'm saying, not for visits. They don't cover any of the Prolo PRP stem cell, but as far as 80% of everything else we do, yes. So, physical therapy, the functional medicine visits, your evaluations with any of the doctors here. We do a lot of different procedures and treatments that do go through the typical insurance carrier. Mm-hmm. But not as far as like the initial evals with Medicare. We take Medicare. Mm-hmm. Yeah.
Neuropathy in your feet that's gone up your legs as well as in your hands?
Yeah, so usually there are treatments we have. It's not usually stem cell, because we don't do like the systemic, stem cell through the IVs that you sometimes hear about to treat kind of every problem out there. We do mostly orthopedic and sports medicine, but we do some work with neuropathy. A lot of times that's the lifestyle. So you're seeing functional medicine. We're talking about why do you have it, maybe some supplements, lifestyle. And then we do have some other types of injections that can be helpful for that too. So we usually have you see both, where you see functional medicine and ortho right away. We usually have you see both of us.
So stem cell really isn't good for the neuropathy then?
Not necessarily, because when you see those results, they're talking about doing not like an IV stem cell, and so it's something totally different than what we do. Yeah. It doesn't mean we can't. We do very different treatments that work very well depending on the neuropathy.
There's a newer treatment that isn't covered, unfortunately, either, that can be helpful. IV ketamine.
Mm-hmm.
Heard of that? It's used for depression. It's used for addicts and that sort of thing as well. But it also has indication for peripheral neuropathy. But I agree. I think cleaning up your health otherwise is definitely beneficial. If you're on cholesterol medicines, those are terrible for your nerves. So sometimes getting you off of those can be a benefit. But there are potentially other options besides the
So
things
that's like
that
an
are.
injection?
It is. And usually it's done multiple different ways. And I've got a colleague in Kentucky that does it. I could pick his brain and get an answer for you as far as what he does for peripheral neuropathy. But he treats everything from depression. He works with people trying to get off opioids, people with PTSD, but it's also got an indication for peripheral neuropathy. But that is actually an out-of-pocket expense too. It's not covered by your insurance at this stage.
Yeah.
I'm pretty dumb, but the stem
No.
cell stuff, is that a shot or what? Tell about stem cells.
Yeah, so it's an injection. It's an injection into the body part that hurts. So stem cell we take from back here. We take it from the back of your iliac crest from the bone marrow. And then they process it to take the stem cells off, and then it gets put into a syringe, and that gets injected under guidance into the body part. So if it's your knee, into those ligaments. If it's into your shoulder, into the shoulder area. So that's why when she was asking about neuropathy, some people have heard about IVs being put back through an IV. And so we don't do those here. We do orthopedic cases, and that means that you treat the body part that hurts, the neck, the spine, the hip. So whatever body part hurts, that gets injected directly into that body part that's damaged or has the arthritis.
So stem cells is part of your cells in your body, you take it off and then put it back in?
Yeah, so everyone has stem cells everywhere. That's why we're alive. So it's what regenerates and keeps your body going. Yeah, and so sorry, I didn't go more specifically into that. So yeah, there's certain cells, and your bone marrow is what makes your red blood cells, your white blood cells. It makes all of your cells. So it's an area that has a high concentration. But you have stem cells technically everywhere. So what you're trying to do is just find an area that you can draw the highest concentration off. So there's going to be other cells in with them when you draw it off from the bone marrow, and then you have either a machine or a lab. We use a lab here that processes that to take that higher concentration. Same thing with PRP, platelet-rich plasma. You draw the blood, they spin it down, and they take off that high concentration of platelets. So you're getting rid of the stuff you don't want, and you're keeping the stuff you do want. So from the volume you start with, what you re-inject is a much smaller volume because you're getting a high concentration of what you're wanting to re-inject. And so it's an injection back into the body part that has the damage. Yeah, yeah. Yeah.
What if you have several things going? What do? Do evaluation and see what needs to be worked
Yeah,
out?
so sometimes we'll just do a general eval to say everywhere hurts. Let's make a plan. Some people will say my back is the worst, or my knee is the worst, my shoulder is the worst, and so they set it up for that. And then when we're seeing them, like I have other body parts, and we say, okay, well let's just schedule you out. Sometimes those body parts are interrelated, so then we can make that decision. Oh, well, your back and hip are interconnected, so we'll just kind of talk about them at the same time. Sometimes you can add certain things on. So usually it kind of depends on if you have one part that's a lot worse, I would make it for that, just knowing that you'll come back for new evals for each body part. If you're not even sure where to start, a lot of times our first visit is just talking through, tell me your story, and then let's make a plan. So I think as long as people know that, most people are they're okay with that. Like they're not expecting me to fix them the first visit, and that we're just going to make a plan to talk through where do we even start, because I think that's sometimes the hardest is where do I start. So yeah.
So everyone gets their own bone marrow?
Yeah. Oh, no. Yep, sorry. Yeah, I wasn't very clear. Sorry. Yes, I did not do a very good job of explaining that. Yes, so you get your own. Yep, and that was the difference when I was talking about the bone marrow and the fat. Those come from you, where the amniotic embryonic come from someone else. So they would take that from an embryo or amniotic fluid. So those are totally different. So where your fat and the bone marrow, they're yours. It's all same day. It gets taken from you that day. It gets processed that day. It gets re-injected that day. Same thing with platelets. It's all yours. Yep.
How long does that process take?
Of a couple of hours. Yeah. Any other questions? Yeah.
Do you ever work in conjunction with like the VA?
So the VA you can get prolotherapy at. You can't get PRP or stem cell. There's some people in the cities. There's a couple of people in our docs that are doing PRP, but trying to get in with them is very difficult. And so my husband's actually a vet, and he works at the VA, and so he does prolotherapy there. So if you ask, are you a vet? Or yep, yeah. So if you just ask your regular doctor there to have a referral to the pain clinic. So he's under it's kind of a pain clinic. He just does prolo and nerve injections and a lot of the lifestyle medicine, so he's not doing medications and the steroid injections. So if you just ask your regular doctor for a referral to the pain clinic, then that goes through the system to him. Then he'll contact you and get you in for an eval. The other thing is if you just want to leave your name and your date of birth for me, I can just give it to him too. As long as you're okay with this, not against HIPAA, I promise. I'm just kidding. That's fine. So you can't get PRP or stem cell, but you can get prolotherapy there. Yep, and nerve injection. So, yes. Platelet-rich plasma. Yep. Yeah.
Can you offer any information about run-ins and hematomas?
What exactly do you want?
As far as if they're already advanced?
And again, so you have to look at the big picture. Is it pain issues? Is it a functional problem? Is there something from your back that contributed to it? So there's usually options. We just have to look at what the problem is. So yes, we do treat bunions. Yeah. Yeah. Do you have another question?
Yeah.
No.
So as far as to know if you have like back problems or lower back, do you do MRIs to see?
So we don't have MRIs here, but we order them. So we have X-ray here, and we do a lot with ultrasound exam diagnostics. But spina is usually yes, MRI. So we just order it. You go somewhere else and have it, and then you come back and you review it with us, and we just look at the images. We get the report and the imaging, and we look at both. Yep. Okay. Yep. Yep. Anything else? Otherwise, you guys are free to go. It's a beautiful night. Thank you for coming in and spending some time with us. We do have a lot of information online if you guys have specifics. And we do have some people who can call you back, too, if you have specific questions. You can leave your name with some integration specialists. We have some regenerative specialists if you have specific questions. But honestly, like I said, the easiest is just bring in your imaging, your reports, set up a visit with one of us to talk through. And if you don't have it, it's fine. We can always start over, so don't stress.
I have a question about getting the information. Now, if I wanted to have my MRI, do you work in conjunction? Is Centricare?
So Centricare, you have to do separate. CDI we have access to. So if you've had it at CDI, we have access to all of their imaging. Anything outside of that, nope. So what you do is you sign a release of records, and you can actually sign one here, where you say you want Centricare to send us information, you sign it. So you sign a release of records for, previous imaging reports, things like that. The one thing I do caution people on and tell them is they technically have 30 days to send their records, and so it gets to be very frustrating because sometimes people will fill out the release and they'll call even and say, yep, we'll send it right away. Well, that person who said we'll send it right away is probably not the person actually in the department that's sending the records. So usually if you do make an appointment and you're sending your records, I just have people call 2 or 3 days beforehand and just check, say, hey, do you have my records yet? Because technically they do have 30 days, and things always happen. They say they mail them, we don't have them, and so people get frustrated. Now that happens every single day. We still see people, we still do our eval. Sometimes we just bring you back for a follow-up and say, okay, once I get your records, because this is what I need to know. Sometimes we're like, okay, I still want these things, but we'll move forward with this step because we can still do something until we get those. So they're not like the end.